Continue our discussion on Chapter 30. For your primary assessment, we're definitely going to identify and treat any life threats. I know that it can be very tempting to kind of skip over the genital area when you're doing your rapid scan, but that system is just very vascular and can produce a significant volume of blood loss. So make sure that you just take a quick look. You don't have to really get too into it, but just making sure that you know that there's not any life-threatening bleeding coming from this area. Your general impression, sick, not sick. ABC is just like everything else. For your circulation, like I just said, there can be a lot of bleeding that comes from this area. So make sure that you're assessing for shock. Closed injuries are not going to have those super visible signs of bleeding, so you might have shock without seeing that bleeding. So just high index of suspicion, control any visible bleeding that you can see, and then transport. Often your issues with your genitourinary system are going to require a medical specialist because they can be super life altering. So there's not a whole lot we're going to do out in the field for the patient. History taking. This is going to allow you to investigate that chief complaint some more. Common complaints that are associated with genitourinary: nausea, vomiting, diarrhea, blood in the urine, again called hematuria, abnormal bowel and bladder habits. So you're going to want to ask about those things. Not only are you urinating, defecating, how often does it hurt, burning, etc. Sample history, OPQRST to learn about the pain. Ask about the output from the genitourinary system. Volume, what does it look like? Is there blood in it? And then ask about any environmental triggers. You want to pay attention to the last intake of food and fluids. This kind of allows you to predict what was going on and how much fluid was in the bladder in particular. So you could rule out full bladder versus not so full bladder. Remember, the fuller that the bladder is, the more easily it's going to be injured. For your secondary assessment, obviously this can be pretty weird to try and assess. You really want to be private, allow them some modesty, let them know what you're doing and why you need to do it, and that should help ease them. Not just, hey, you're checking me out because you want to check me out, but you are significantly concerned for this, that, or the other. A quick look, no internal, I shouldn't even have to touch you. I just want to just take a quick peek because of this. Focus on a specific body region when you have an isolated injury. Obviously, if somebody fell and broke their arm, there's no reason to assess the genitals. It just common sense a little bit. DCAP BTLS, identify wounds and control bleeding. Start with that head to toe just to make sure that you're not missing any trauma. Vital signs, make sure that you reassess your vital signs based on the possibility of your patient changing significantly. If your patient has tachycardia, tachypnea, low blood pressure, weak pulse, cool, moist, pale, clammy skin, any signs of hypoperfusion, essentially, you're going to want to take your vital signs much more frequently. And this should allow you, the best information is to rapid transport or not if you're not transporting here. And then make sure that you use pulse ox and non-invasive blood pressure devices. That's all we use in the field. We don't use arterial, so I'm not sure what they're getting at here. But reassessment, Start with the primary, roll through the vital signs, check for your bleeding, make sure that you've got it under control, check for shock. A lot of this is going to be placing the patient in a position of comfort for transport and then letting the hospital know what's going on as well. Specific injuries, kidneys, damage is probably not going to be obvious. You may see signs of shock. They may tell you that they have blood in the urine, but for the most part, you're not going to see a lot of those outward signs. Pain is going to be more what you'll hear. So treat for shock and transport. Bladder injury, if you have blood at the urethral opening or signs of trauma to the lower pelvis, abdomen, peritoneum, etc., just suspect a bladder injury. In the presence of shock or an associated injury there, go ahead and transport. For male genitalia, try and make the patient comfortable because these are going to hurt. If you have areas of stripped skin, you can use sterile moist compresses. Apply direct pressure with dry gauze to control bleeding. If for some reason there is a foreign object stuck in the urethra, we're not moving it around, let it go. Just if the patient has an avulsion of skin on their penis, you want to wrap it in a soft, sterile dressing, moistened with saline, transport promptly. You'll use direct pressure to control any bleeding, and you want to try and save or preserve that skin. Remember, we don't take it off unless it's completely dead, because oftentimes the hospital can fix it. Even if it's dead, let the hospital take care of it. An amputation of the penile shaft. The biggest thing is managing blood loss. You don't have a bone to actually compress against in order to use a tourniquet effectively. If you end up using a tourniquet, basically what you're going to do is compress the tissue, but you're not actually pressing it against anything. So it's really not going to do a whole lot. So we're not going to apply a constricting device because it's not going to take care of the issue. You need to take care of the part associated, wrap it in a moist sterile dressing, place it in a bag, and transport with the patient, typically out of sight, because this is going to be pretty darn traumatic. But surgical reconnection is possible, so make sure that you take care of it. If the connective tissue surrounding the erectile tissue is severely damaged, you can actually get, they call it a fracture, but it's really not because there's no bone to break. But you can get angulation of the penis that, again, is very emotionally traumatizing. Sometimes it does require surgical repair. Injury may occur for several different reasons, but it is more common with like very active, intense intercourse. Yes, it is possible to quote unquote break the penis. It's associated with like massive intense pain, bleeding into the tissues, and a lot of fear. Laceration of the head. It's generally associated with heavy bleeding just because there is a lot of bleeding, obviously, in this area. Usually just some local pressure with a dressing is going to stop it. If for some reason the skin of the shaft or the foreskin get caught in the zipper, it's really, truly not an uncommon event. And they may call for help because, I mean, when you see your pride and joy zipped up into your pants, it's a little intimidating. If it's just a small segment of the zipper, you can try and unzip the pants. If it's a much longer segment, use your trauma shears to cut the zipper out of the pants and leave it attached to where it is. Make sure that you give them a heads up exactly where you're going to be cutting and be very gentle with how you cut so that you don't end up accidentally cutting the scrotum. Urethral injuries are definitely not super uncommon. Um, Lacerations can result from like a straddle injury. So they're on a bike and their feet slip off the pedal and they end up slamming down. Pelvic fractures, any sort of penetrating wound. It's important to know if the patient can urinate and if there's blood in the urine. So definitely ask them about the possibility of any of that. Um, any foreign bodies in the urethra will have to be surgically removed. We're not pulling them out ourselves. An avulsion to the skin of the scrotum may damage the contents underneath. Try and preserve the full skin just like everything else because it's more than likely they'll be able to reconstruct it. Wrap the contents or the perineal area with a sterile moist compress and then just local pressure to try and control your bleeding. If you have direct blows to the scrotum, you can actually rupture a testicle or you can get a significant amount of blood in or around the testy. So apply an ice pack and provide emotional reassurance. For female genitalia, same thing. Any lacerations, avulsions with a moist, sterile compress, use local pressure, and then you can actually hold your dressings in place with a diaper type bandage. We're not packing the vagina. We've already discussed that before. If there's any foreign bodies in place, just stabilize it with a bandage. We're not taking it out. Same with males. Oftentimes your injuries are painful, but they're not life-threatening. However, because of the sensitive nature and the possible long-term implications, they should have an in-hospital evaluation. For rectal bleeding, it's a very, very, very common complaint. Bleeding may soak through undergarments, or you have a bowel movement and it passes either into the toilet or you notice it on the toilet paper itself. There are several different causes. It can be sexual assault, rectal foreign bodies, hemorrhoids, colitis, ulcers, hemorrhoid surgery. So there's quite a bit of potential causes here. For sexual assault, unfortunately, these are very common. Victims are generally going to be women, but it can be men and children as well. There's very often very little that we're going to do for the patient. If they've sustained some sort of multi-system trauma, then we need to assess and treat for shock. But otherwise, you don't want to do much for this patient. We're not going to do a whole lot of examining unless they are bleeding relatively significant and you have to put a dressing on. We're not touching them. A lot of times they won't want you to touch them anyways. They're going to be very shy, physically scared. Try and shield them from onlookers. Document their history, assessment, treatment, response for possible court appearances, but don't speculate and record only the facts. If you need to record something in particular, it's patient stated and then put in direct quotes. Advise the patient not to wash, bathe, shower, urinate, defecate, etc. until you get them to the hospital, because this could wash away significant evidence, but I will tell you that your patient is going to want to wash, to bathe, etc. So this might take some convincing here. If oral penetration has occurred, they shouldn't be eating, drinking, brushing their teeth, using mouthwash. Again, they're going to want to do those things, so trying to talk them down a little bit. When you're handling the patient's clothes, try and do that as little as possible so that you don't lose evidence that's on there. You want to place them in paper bags, not plastic bags, because if they're moist and you put them in plastic bags, you can get mold on them. Try and keep the patient the same gender, the medic or EMT the same gender as the patient, and provide a lot of reassurance. This is the end of Chapter 30.